Good afternoon, everyone. First of all, let me thank you all for coming here today. It's my pleasure to give this talk, so thank you for the invitation. As you can see on the screen, the topic is obesity and subfertility. Actually, I changed the topic title. It was obesity and infertility to obesity and subfertility because of the huge difference between them. Infertility is an absolute inability to conceive, like a woman without a uterus, a man with zero sperms, but subfertility is a situation where the couples are facing difficulties getting pregnancy. So this is the outline of my talk. I'll start by defining some terminologies that I will use in this talk. I'll talk about normal natural fertility, the causes of subfertility, the effect of obesity on fertility, fertility treatment, and on pregnancy, and then I'll talk about male obesity and subfertility. These are some terminologies that I will use. Fertility is the ability to conceive, to have a clinical pregnancy. Subfertility is inability to establish a clinical pregnancy after 1 year of regular unprotected sexual intercourse. Cycle fecundability is the probability of achieving a pregnancy in a single menstrual cycle. Cycle fecundity is the probability that a cycle will result in a live birth. Sterility is a permanent state of subfertility. Time to pregnancy is the length of time, usually measured in months, that takes a couple to conceive. Obesity is when the BMI is greater than 30 kilograms per meter squared. Overweight is when the BMI is between 25 to 30. What is normal natural fertility? Most of the pregnancies occur in the first 6 cycles of attempted pregnancy. So by 1 year, about 85 to 90% of the couples will conceive, and this gives us 10 to 15% of couples who will suffer from subfertility. How does conception occur? For a pregnancy to occur, we need ovulation, we need patent normal fallopian tube, we need normal endometrium, which is the lining of the womb, and we need good number of morphologically normal, progressively motile sperms. What can go wrong? What are the causes of subfertility? When you look at the woman alone, 40% of the causes of subfertility are ovulatory dysfunction. Tubal and pelvic pathology are responsible for 40% of the cases. 10% are due to unexplained infertility, 10% due to unusual problems. And when you look at the couple, 35% are caused by male problems, 35% due to tubal and pelvic pathology, 15% due to ovulatory dysfunction, and then 10% and 5% due to unexplained and unusual problems, respectively. What can go wrong? How does obesity affect that? In order to understand that, we need to go back to the normal menstrual cycle. This is the famous menstrual cycle diagram. This is the follicular phase and the luteal phase. The follicular phase will start with the menstruation after the death of the corpus luteum in the previous cycle. The corpus luteum was supporting the body with estrogen and progesterone for 14 days. And when the corpus luteum dies, the estrogen level will drop. This drop in estrogen will start the next cycle. Because of this drop in the estrogen, the FSH will increase as a negative feedback effect on the pituitary. So with the increase in the FSH, the follicles start to develop until it reaches the point of the ovulation. Actually, this diagram is just for simplicity. What happens in reality, it's not only one follicle that develops every month. There is a cohort of new follicles that develop every month. And when they develop, they will produce estrogen. This estrogen will cause the drop in FSH. When the FSH drops, the only one good follicle that will develop, the other follicles will have apoptosis, the programmed cell death. And this is called the FSH window. This window that we use in the IVF cycles. When we use all of these follicles, we rescue them from apoptosis, and we get many eggs in the IVF cycle after the egg collection procedure. Now, obesity predisposes to chronic anovulation in at least 3 distinct ways. Number 1, increased peripheral aromatization of androgens, resulting in chronically elevated estrogen concentration. So when we go back to the diagram, the estrogen level will be high. So high estrogen level will not increase the FSH. So there will be no follicular development and no ovulation. Number 2, decreased levels of sex hormone binding globulin will lead to increased concentration of both estradiol and testosterone. Again, the same thing. The estrogen level will be high, FSH will not increase, and no development of the follicles. Number 3, because of the insulin resistance in obese women, there will be high local androgen in the ovary itself, which will impair the follicular development. So it will affect the ovulation. The adipose tissues in obese women will increase the level of the leptin. Leptin will affect both the ovaries and the endometrium. It will alter the maturation of the oocyte, and it will affect the receptivity of the endometrium. Now, the fat distribution, does it matter? This is a study published in 2010 when the authors looked at the association between the fat distribution and the ovulation. They recruited 40 anovulatory obese women and 17 ovulatory obese women, and they measured the fat distribution by DEXA scan, by single-slice CT, and by some physical measurements. And they found that anovulatory women had a higher waist circumference, more trunk fat, and more abdominal fat than ovulatory women who have the same BMI. So yes, it matters. Ovulatory dysfunction is likely compounded by the diagnosis of polycystic ovary syndrome, but I'll not go through this in this talk. Obese women who have regular cycles, which means regular ovulation, also have some difficulties in getting a pregnancy. And this was attributed with the hormonal impairment, short luteal phase, prolonged follicular phase, low amplitude of the LH, so it's not only the ovulation. It's not only the weight of the obese woman, it's the increase in the weight that causes subfertility. Here is a prospective cohort study of nearly 2,000 women reported that every 5 kilograms body weight increase from the baseline was associated with a 5% increase in the mean duration of time needed for attempted conception. And 90% of those women were ovulating regularly. So again, it's not only the ovulation. Now, moving to the fertility treatment. These are some of the fertility treatments that we use in the assisted conception unit. For ovulation induction, we use aromatase inhibitor, selective estrogen receptor modulator, and we use low doses of the gonadotropins. But for IVF cycles, we do stimulation, not induction, so we use high doses of the gonadotropins. For ovulation induction in normogonadotropic anovulatory women, increased BMI and abdominal obesity are associated with decreased odds of ovulation in response to clomiphene citrate. Actually, in normal BMI patients, we start our cycles by induction of ovulation with letrozole of 2.5, clomiphene citrate of 50 milligrams. But with obese patients, we start with high doses. We know that they will not respond with these doses. We start with letrozole of 5 milligrams, clomiphene citrate with 100 milligrams, and again, the pregnancy rate is lower. And with ovulation induction, with the gonadotropins, women with obesity treated with gonadotropins for induction of ovulation require, again, higher doses of medication and produce fewer follicles at a given dose. What about the ARTs, the assisted reproductive technologies? ART means either IVF, in vitro fertilization, or ICSI treatment, which is intracytoplasmic sperm injection. Again, when we start the cycle for obese women, we give them high doses. And on average, with normal BMI patients, they take like 10 to 12 days for stimulation. But obese women will need like 14 or 18 days. And most of them will have their cycle canceled because of low response. Here is a picture of the eggs with the cumulus complex. This is how we look at the eggs under microscope after the egg collection. Obese patients will have small eggs. The quality of the eggs are poor, and the fertilization rate is low, and hence the pregnancy will be low. And this is why in the UK, if you want to apply for NHS-funded IVF treatment, you need to have a BMI of less than 30. But if you want to go for self-funded, they will accept a BMI up to 35. In Kuwait, we offer free treatment for a BMI of 35. Okay, in summary, increasing BMI is associated with lower ovarian responsiveness to ovulation induction, as evidenced by the need for higher doses of oral agents and gonadotropins, and the lower number of oocytes retrieved during IVF. Oocyte quality is impaired in obese women. Higher BMI is correlated with lower implantation and clinical pregnancy rates and live birth rates when undergoing IVF or ICSI. What about the miscarriage? In unassisted conception, like in pregnancies without fertility treatment, obese women are 1.3 times more likely to have pregnancy loss. With ART, the risk is even higher. Most of the miscarriages in the general population is due to aneuploidy. Aneuploidy is abnormal number of the chromosomes. But in obese women, when we looked at the products of conception, we found that more than half of the miscarriages are euploid, which means they are normal. So high BMI is an independent risk factor for the miscarriages. Now, does obesity affect pregnancy? Maternal obesity is associated with increased obstetric and neonatal risks. Obese pregnant women are at risk of gestational hypertension, gestational diabetes, large for gestational age babies, and we face difficulties in the clinics when we want to assess the growth of the baby, and we need to estimate the gestational age. Here we can see, we use this tape in the clinic to check for the growth of the baby. So imagine that this is a 20 weeks pregnant lady, so the fundal height should be up to the umbilicus. But with the in obese women with the fat, you might find the tape going up to 36 weeks. So it's difficult to estimate that, and we need to do serial growth by the ultrasound. Okay. Studies found that improved ovulation rates and menstrual regularity have been demonstrated with modest weight loss through lifestyle modifications with and without adjunctive weight loss medications in obese women. Correction of amenorrhea occurs in several women with obesity after bariatric surgeries. Now let's move to the obesity and male reproduction. It's well known that couples with an overweight or obese male partner with a female of normal BMI have increased odds ratio for increased time to conceive compared with couples with normal weight male partner. How can we assess the semen analysis? How can we look at the sperms? As per the WHO in 2010, we look at three things. We look at the concentration of the sperms, the normal morphology, and the progressive motility. The concentration should be more than 15 million per ml. The progressive motility should be more than 32%, and the normal morphology should be more than 4%. Several studies looked at the association between obesity and these semen parameters. Some studies reported that obesity is associated with decreased concentration of the sperms, so it will lead to oligozospermia. Other studies found that obesity will reduce the progressive motility of the sperms, and this is called asthenozospermia. Other studies found that obesity will lead to reduced number of normal morphology, and this is teratozospermia. Why does that happen? Obese men have high sperm oxidative stress, and they also have high degree of DNA fragmentation. This fragmentation and oxidative stress will lead to oligozospermia and asthenozospermia. This is one explanation. The other explanation is the hormonal impairment. Of course, obese men will also have low sex hormone binding globulin. Then they will have high estrogen and testosterone level, which will impair or disrupt the negative feedback loop on the hypothalamus pituitary gonadal axis. So the production of testosterone will be less. Obese men will also have hyperinsulinemia and hyperglycemia, which is shown to have an inhibitory effect on sperm quantity and quality. It's known that the scrotum of the obese men is in close contact with surrounding tissues than in normal weight men, which will increase the temperature of the scrotum that will lead to altered semen parameters. It's also known that obese men have sexual dysfunctions, so it will, of course, affect the fertility. In summary, in women, obesity is associated with menstrual dysfunction, decreased fertility, low success rate of ART, increased risk of miscarriage, increased risk of obstetric and neonatal complications. And in men, it is associated with abnormal semen parameters, increased DNA fragmentation, and sexual dysfunction. Thank you.